Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you, Brian. I was searching for a topic for this week, and so I'm actually glad, Brian, that you asked me to look at it. Just my disclosure, we may talk about things that are not currently FDA approved. This is the standard ECHO disclaimer. And the reason why we're anchoring this talk today in this new bill that became effective on January 1st of this year, it is, of course, relevant to those of us who are in the state of Washington. But those of you who are not in the state of Washington, your states may be contemplating doing something similar. So this was a bill that was introduced in the last session of the Washington State Legislature to increase access to HIV post-exposure prophylaxis. And we are one of two states to have a law something like this. The other one, I believe, if I remember correctly, it was in Rhode Island. I mostly remember that it's not one of the states where you all are likely from. So what this does is to increase access to post-exposure prophylaxis, particularly in places that are more rural, less connected to pharmacies, to make sure that people can get post-exposure prophylaxis within a reasonable time frame. So this is the law. I have two slides that basically lifted the text from the law. It's literally cut and paste. I only shortened CDC and HIV here. And so it is requiring all hospitals to have procedures and policies in place to be able to dispense post-exposure prophylaxis. And the policy requires hospitals to dispense a full 28-day supply so that they can ensure they can get that. Again, the goal being increase access to post-exposure prophylaxis. Of course, normally I'm talking about pre-exposure prophylaxis. What we're talking about is when someone comes in and believes that they may have been exposed to someone with HIV, either through sexual risk or injection drugs, that they take a 28-day supply of what has been 3-drug regimen for the 28 days following that exposure. The other part here, the comment in the law, is that the hospitals shall dispense or deliver generic HIV post-exposure drugs or therapies. My second slide is just the language about health insurance plans. There is similar language for the expanded Medicaid or Apple Health plans, but that the health plan that is not grandfathered is not supposed to impose any cost sharing or require any prior authorization for drugs that comprise at least one regimen recommended by the CDC for post-exposure prophylaxis. And we are going to come back to this language. And the health plan is required to reimburse the hospital for that 28-day supply that has been delivered, and that is supposed to be distinct from the reimbursement for the emergency department or other visit. So I just want to use this to sort of as the jumping off point for this conversation today, because we're going to talk a little bit about post-exposure prophylaxis in general. So this is the case. This is where I'm going to ask you to vote. So you're going to see a new patient. This is going to be in a clinic, but they're coming in for initial PrEP visit, so pre-exposure prophylaxis. He's 26. He moved to your city 3 months ago, and since moving, he's had receptive and insertive sex about every other day or so, with about 50 partners, with the last condomless sex being last night. He has no medical history meds or any substance use, and you do a point-of-care HIV test in the clinic, and it is negative. So the question is, what do you prescribe today? So the first is nothing. No medications, and just repeat testing in 2 to 3 weeks. Option B is FTC-TDF, that's M-tricytamine tenofovir disoproxil fumarate for 30 days with 2 refills. Or option C, FTC-TDF plus raltegravir for 28 days, FTC-TDF plus dolutegravir for 28 days, bictegravir, M-tricytamine plus tenofovir alafenamide as a single pill for 28 days, or do you give him an injection of cabotegravir rilpivirine? I'm going to let you vote. Probably, hopefully, all of you have made your decision. There's no right answer here. If you're worrying about which is the right answer that I'm seeking, there is no one right answer. There is a wrong answer. There may be 2 wrong answers. So more than half using dolutegravir, smaller proportions doing bictegravir plus FTC TAF as PEP, a slightly smaller proportion doing PEP with raltegravir, and then a good sized minority starting PrEP today. So I'm going to move on to the next slide. The reason why I gave a pep talk it was surprisingly last was 5 years ago. So again, Brian, thank you for encouraging this. So I really like this from the guidelines, but one of the things you'll note is that our nPEP guidelines are from 2016. So hopefully this language continues in the updated guidelines, which we are expecting soon, but that we're providing nPEP only for infrequent exposures and that people with frequent exposures should be prescribed PrEP instead. It's 2016, so what they're recommending is FTC-TDF for PrEP. However, if the most recent recurring exposure is within 72 hours before, so within that 3-day window, that we may do nPEP, as many of you suggested, transitioning the patient to PrEP after that 28 days. I really like this language. It's really interesting to me that at least the newer PrEP guidelines have lost some of the conversation about the PEP to PrEP transition. So again, as many of you would, I would have had a conversation with this person about prescribing PEP, so at 28 days of 3 medicines, and then transitioning to PrEP. But it may be reasonable, and we were going to talk about this, about starting this person on 2 drugs at the time and just continuing with PrEP. I am going to briefly touch about what I think you're going to see in the changes to the guidelines. What I'm showing you here is the who and when. The slide itself is copied and pasted from David's National HIV curriculum. Again, this is from the 2016 guidelines, but it is commented that someone who has had substantial risk within the last 72 hours, and it includes what is considered substantial risk, that those folks should be prescribed non-occupational post-exposure prophylaxis or nPEP. But if you've heard me talk, that we're expecting new guidelines. And so I'm going to give you a hint here of what I think you're going to see. And then once this talk is over, we can have more discussion about what I think the nuts and bolts of those changes are going to be. But I think one of the things you're going to see is that there's going to be more discussion about indications for PEP and a change to emphasize the urgency of administering nPEP. So while the guidelines allow for PEP to be started within 72 hours of exposure, and in some cases you may extend that if there is really high risk of HIV transmission, there is going to be an increased emphasis on urgency of PEP and starting within the first 24 hours. I believe that you're going to see a change in those first-line 3-drug regimens, which are currently FTC-TDF plus raltegravir and FTC-TDF plus dolutegravir, may or may not even be in that current first-line regimens. Changes in laboratory testing related to HIV testing and monitoring. Hopefully, a lot of these will align with the PrEP guidelines and the PEP to PrEP transition. At least that was my recommendations when I reviewed these guidelines. I sadly think that we may see some more emphasis on HIV nucleic acid testing, which we're seeing in the PrEP guidelines, but I do not know that for certain. I have not seen the final guidelines yet. But I want to go back a little bit to that question of 2-drug PEP. So starting someone who's had a recent exposure on 2 drugs and essentially the 2 oral PrEP medications. And there's been more conversation about this recently, both locally and as part of the guidelines, because the WHO have said that 2 drugs can be effective, but 3 drugs are preferred. So they consider 3-drug regimens to be first line, but 2 drugs to be an exceptional alternative. But Australia actually recommends only a 2-drug regimen over a 3-drug regimen for PEP. Again, we're talking about post-exposure prophylaxis. And I've lifted the quote from their guidelines here that there is no evidence to support the greater efficacy of 3 over 2-drug regimens. There may be cases where you are going to prescribe 3 drugs, but the rationale for using 3 drugs over 2 drugs, and if those of you who have been around like I have for a while know that we used to do PEP with 2 drugs, that The rationale for 3 drugs is because that in HIV treatment, we know that at least in the initial 3-drug regimens, that those were more effective compared to a 2-nucleoside reverse transcriptase inhibitor-based regimen. If you want to frame it the other way, there's limited data to suggest that 2 drugs is not inferior to 3 drugs. It's sort of, are you a glass half full or glass half empty? But we do not have any data because we have really limited data about the efficacy of PEP in general, but we do not have data about superiority of 3 drugs. So that's why in some cases, particularly if you do not feel that the PEP indication is super high, why it may be easier to get access to 2 drugs and therefore start someone on PrEP on the day that you're seeing them. And that may be effective as PEP, just how you frame it. The question of injectable post-exposure prophylaxis hasn't been studied, but there's a lot more interest also in this idea of having PEP in pocket, or with the abbreviation of PIP. And so what this is, and this is routinely done in Toronto. So it is a way where people who may have real but infrequent exposures to risk for HIV acquisition, to get them access to post-exposure prophylaxis medications if there is an indication, and get it to them in a way where they do not have to seek attention. If it's a weekend, wait a couple days to get into a clinic visit. And this is done, I would say, routinely in Toronto, and they have not documented any PEP failures, with all of the caveats about how hard it is to document PEP failures. And you can see some of the references that they have published about their programs. One of the things that I was looking into related to this, so when I reviewed one of these papers, I had asked them to comment about whether or not they were getting prescriptions, paper or electronic prescriptions, or actually bottles of dispensed medications. And this method is giving someone prescriptions. So they still have to go through the pharmacy in order to get the access to this for the most part, although people can get their pills. I've had patients who have wanted to have actual pills at home. And the question is medication stability. And I appreciate Bob and G responded to me in a question, as well as the folks from Kelly Ross, about understanding stability of these medications. And it's actually really challenging to find this information. So I could only find it for a subset of the medications used as PEP. That's all I looked for. The one thing I could find that in a sealed bottle, that dolutegravir has been shown to be stable, again, original sealed bottle for 24 months, but that once you break open that seal, that those bottles are only good for 30 days, in some cases to up to 6 weeks. Again, I did not find information for all of them, but if you're handing someone a bottle and you've opened it up and changed from the 30 days to 28 days, because that's what we're dispensing as PEP, that bottle is only supposed to be effective in ideal conditions for 30 days to 6 weeks. We know, of course, that expiration dates are expiration dates, but that's what the FDA says is okay. So I'm going to take this back to our bill, because when I emailed about this, it raised all sorts of frustrations, shall we say, about how this bill is going to be implemented. Again, a Washington state limited bill where hospitals and emergency departments will be required to hand someone a full prescription of 28 days for PEP if they come in seeking care. And so these are the concerns that I thought about, and that some of the pharmacists who responded to me thought about. The first is that it's going to require advanced purchasing. This is the way pharmacies work. So they will have to buy these medications, that the insurance is going to have to reimburse them for the medications that they've already purchased. I won't say much more about that. But one of the real issues is that pharmacies are going to be purchasing 30 pills, but only dispensing 28 pills. And for those of you who heard me talk about pharmacies before, those of you who are pharmacists know that the gross margin on prescription medications is actually on the order, perhaps, of under 10%. So this may result in pharmacies losing money because they will only be reimbursed for 28 pills, even though they will probably want to dispense 30 pills. There are sort of other sort of questions I had about the specifics about generics that we talk a little bit about. Dolutegravir remains on patent until 2028. And there actually is a generic raltegravir that was FDA approved just a couple months ago, may or may not be commercially available yet. And I couldn't find anything about price. What we know about when FTC TDF went generic, that for the first year that it was actually the equivalent price of the brand name. And so I don't know what the cost is going to be. And then, of course, there's the question of assessment and follow-up and how this is going to be done from each individual hospital. So will PEP be overprescribed? Will it be given to anybody who comes in who has perhaps any low-risk indication? Will be underprescribed because there will be challenges about follow-up, and where will that follow-up occur? So I think we're very early into sort of implementation, and I don't have any answers to these questions, but I think it's going to be interesting to see how it plays out and whether it plays out the way that people thought it would.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.